actually a cricothyroidotomy. It's not. Tracheostomy should happen really here between the first and second tracheal rings, and then you'd be able to put it in smoothly. But let's say it's here. So if it's here, should the obturator be there?
No.
No. So this should always be out so the patient can breathe in and out. Otherwise, you're going to suffocate the patient, right? And then if the patient, I'm just going to pretend here. So let's see. They've packed it really well to the point you can't even get it off. But I'm just going to hold it like this, okay? So, sorry, it's going to be like this. Yes. I'm going to hold it like that. So when you're getting ready to provide tracheostomy care, you want to assess the patient first, right? And then you get ready. So you put your mask on, wash your hands, put gloves on, and then you get all the stuff that you need ready. What are the things you would need to provide tracheostomy care? Out of pronunciation. So bear with me if I say saline, okay? Saline, all right? So have that ready, and then when I asked for other cleaning agent, we also use hydrogen peroxide, half and half. So we put half amount of hydrogen peroxide, half amount of saline. That is not necessarily for the stomach care, that's really for the inner cannula. Because the inner cannula may have dry secretions that will be very hard to clean with the regular saline. So we take it and we soak it in half and half hydrogen peroxide while we clean the stomach here. So let's see what we get. Okay, so then you would take this gauze with the forceps or artery clip, and you dip it in.
Bowl with dollars.
Okay, thank you. And then you go around and clean the stoma. So when you're cleaning, you actually have to go underneath the flanges also, and then around the stoma. Usually under the flanges, you'll find a nice little ring of rust. So you have to soften that and get that out. Sometimes, so just go around. We're going to pretend right now. And you can't go underneath there. That's going to be skin. You want to come? Sometimes you may even have to remove the the string. But if you are removing, make sure you have another person with you in the room. So one person is holding, because sometimes if the patient coughs, the tube will come out. So you need someone to secure it while you're getting. If the stoma doesn't look too bad, then you can just go in and clean real quick. But the key thing is to go under the flanges to get it out. And then you take the inner canal out, you're soaking it in, half and half hydrogen peroxide, but then you take the inner canal out, rinse it with saline, because you don't want to put hydrogen peroxide directly into the airway. And then you take the clean one, maybe even let it air dry. So that's why I was telling you before, always have a clean inner cannula at the bedside. So I usually, when I take that out, let it soak, take the clean one, put it in, sterilize the patient, and then when that is air dried and ready, to be ready for the next time. So we do this tracheostomy care every 8 hours and as needed if the patient has bleeding or like if they have a lot of sputum, phlegm secretions coming through that. So that's the tracheostomy care. Now suction. Let's talk about suction. Is there a suction catheter? Then from the wall suction, do you have wall suction or the gland?
Both.
So you should actually set up everything first before you even put the gloves on. I'm just going to take my hand off so I can talk a little bit more freely. So when you put the gloves on, in my mind, I say, if I'm a right-handed, I say my right hand is always sterile. My left hand becomes a clean hand, even though it's still considered clean because you are going to touch something that's not sterile. So you already have the wall tubing set up, right? Then you take the suction catheter at this end. So then you consider your right hand. Is it okay if I put my hand just to show you? Okay, so you have this ready, right? So you kind of do that. And then what I do is I kind of hold this like this. So my right hand is sterile, it's all ready to go. I'll actually touch the unclean suction catheter, hook it up here, and then I will actually use this portion. This blue portion will be considered clean, this is sterile. So there is one more piece that comes here that I'm not seeing, which is the white connection. We have something called as a thumb port, right? Is that the white connection you're talking about? That's right. So can you hold the suction tube for me? No, I meant suction. Tracheostomy tube, sorry. It's not going in, just hold it. Okay, great. So if the patient has that, so now this is my clean hand, it's all hooked up, and I have my thumb on that thumb port. So when I'm going in, I do not press the thumb port. Okay, if you go in and like you are here and you start using thumb port, it can traumatize the patient. So when I'm going in, I don't use the suction. Okay, but then on my way out is when I suction it out. So some people like to go like this, but every time you let go, the secretions will fall down. So usually I hold it, bring it out, and then let go. How long should the suction catheter be in there? Less than 10
Less than 10
Okay.
seconds.
So you can count, or sometimes you can hold your breath so you know. But we may be able to hold the breath longer than a patient who is sick. So we have to be considerate of that. If you need to come out, give them some time to breathe, and then you go back in if you have to suction. Now, how far can you go down? Till you feel a resistance and then suction.
No.
That is the traditional way that we used to do, but now we're actually changing that practice because if you go down, what is the resistance that you're feeling? It's the carina, right? So if you hit the carina, people say pull it back a little bit, but even if you pull it back a little bit, sometimes you could pull the carina with it, right? So usually what we're saying is that if you know it's this size straight tube, even before you go in, you pre-measure it. So we usually keep one trach tube. So we say the length of the tracheostomy tube plus 1 centimeter. So that way when you go in, you're doing tracheal suctioning, you haven't hit the carina. Every time you hit the carina, imagine if someone takes a plastic and hits the carina. The medical resident kept saying, patient's having bleeding, patient is having bleeding. I'm a consultant, so sometimes residents will call me to come see the patients. When I went and scoped the patient, it was like a polka dot design in there. Every time you touched the wall, you were taking a little bit of the mucus out. So it's very important that if it's not an emergency situation and you have the time, measure to the length of the trach tube plus 1 centimeter. Then you can safely go in and not hit the carina. Okay? Instead of hitting the carina and then pulling back, because we're not trying to do a bronchoscopy here. We're only doing a tracheal suction. So we just have to be in the trachea. And then you can suction it. Any questions about that? I'll try to breeze through this quickly, maybe 5 minutes. Okay, let's see if I can do that. So complications. If there is bleeding around the stoma, what do you do?